Thank you to the American Liver Foundation for inviting me to provide the CDC update on our liver cancer prevention and control initiatives. Since 1998, CDC has funded the National Comprehensive Cancer Control Program. Today, we fund 50 states, DC, as well as 8 Pacific Island jurisdictions, as you can see on this map, and 7 tribes or tribal organizations. The goal of the national program is to fund, provide guidance, as well as technical assistance and support to these programs to design and implement strategic, impactful, and sustainable cancer prevention and control plans. Our key priorities are included here in this slide, and you can see at the top, you see the 3 what we call core priorities. The first one is to emphasize primary prevention of cancer. And our work in this space includes increasing vaccinations of HBV as well as HPV, promoting tobacco-free living, promoting sun safety, as well as improving nutrition and physical activity. You know, Dr. Guy mentioned the importance of that. Our second core priority is to support the early detection and treatment. And our work in this space is to promote our recommended screenings. And Dr. Guy also touched a little bit on that, and I'll go into that a little bit more. Support the appropriate treatment and financial barriers for our patients, as well as improve access to clinical trials, use patient navigators, as well as community health workers to provide the required services, medical and social services to patients. And then the third here is to address the public health needs of cancer survivors. And so we offer survivorship programs as well as support survivors care plans as well. Now, my role as a health scientist in our division is to lead the division's liver cancer prevention work. And I work very closely with the epidemiologist and the health scientist in CDC's division of viral hepatitis as well. As you know, that is a major risk factor. And as you can see here on the slide, and as Ivory mentioned in my bio, I also co-chair the Vaccine Preventable Cancers Group, which is a priority of the Comprehensive Cancer Control National Partnership, of which CDC is one of 19 national partners. And we really, our goal here is to provide strategic direction as well as support to our coalitions on the ground that are working with our programs and are the backbone to a lot of the interventions that are implemented by our programs. So translational research, so putting the evidence base and the promising practices of what we know works in the field, translating that into the field, working with communities that are disproportionately affected by this disease is critical to our work. Let's see, in 2019, prior to 2019, the Vaccine Preventable Cancers was primarily focused on HPV. And I was asked to serve as co-chair to expand the focus of the work and to incorporate HPV. So now it is a priority of this partnership, and I'm happy to see that change. So CDC's work in liver cancer prevention began in 2010, and myself, along with my colleagues in the Division of Viral Hepatitis, published our MMWR, what we call the Morbidity and Mortality Weekly Report. And this was looking at population-based estimates, so looking at data from 2001 to 2006. Hepatocellular carcinoma, and this is primary liver cancer. And we published the data, and our findings show there was a continued increase in hepatocellular carcinoma incidence. We also observed 11 states that had significant increases in their incidence rates. And then we also observed these specific communities that were disproportionately affected. So Asian Pacific Islanders were disproportionately affected, Blacks, as well as American Indian and Alaskan Natives. Now, that same year in 2010, the National Academies, it's formerly the Institute of Medicine, released a national strategy for the prevention and control of hepatitis B and C. And so they included these 4 areas where they provided recommendations that federal agencies, including the CDC, should be engaged in to help prevent the disease. And so the first is surveillance. And this is not just active targeted surveillance, but also evaluation of our surveillance systems. The second was to support outreach and educational programs to really raise awareness of the knowledge, and knowledge of hepatitis B and C virus infections. And then the third was to promote vaccinations, the hepatitis B vaccination. And then the fourth was to improve our delivery of viral hepatitis services. And in this space, that includes providing the resources for the expansion of community-based programs that offer screening and vaccinations, medical management, as well as access to our sterile needle syringes. So in 2010 and 2015, we spearheaded a review of our cancer plans. And so this is where I really wanted to look into our cancer plans from the programs, the funded programs, to see if we can identify what goals, what strategies and activities that they were engaged in related to liver cancer prevention. And what we found was that most of the cancer plans did not address this connection between chronic HBV or HCV infections and liver cancer. And very few plans actually mentioned any type of prevention activities to reduce the burden of liver cancer. There were states that had these larger Asian Pacific Islander populations that were more commonly reporting addressing HCC, and then some plans targeted specific populations like the American Indian and Alaska Native. In 2015, to supplement the review, what we decided to do was take a look at the published literature to identify what were these additional liver cancer prevention strategies that can potentially be implemented in our national program and have support from our coalitions. And these strategies were then organized into the 2010 National Academies report that I mentioned, those 4 areas, and we published this information in Cancer Causes and Control. So at the time, I mentioned the 2001 to 2006 MMWR. And in 2017, we have the United States Cancer Statistics Data Visualization Tool. We looked at the data from 2006 to 2015. And you can see here, when you look at this data, when you compare it, well, first you can look at on the left side, you can see that figure, all types of cancer. When you look at the data, they were on the decline. But when you specifically look at liver cancer, from 2006 to 2015, we saw the incidence increased by 32% and the death rates increased by 25%. And so what we knew here, well, one, that was a problem. And what we knew is that liver cancer is preventable. Globally, approximately 78% of hepatocellular carcinoma has been attributable to chronic HBV or HCV infection. What we also knew at this time was in the US, 66% and 39% of people that were infected with hepatitis B and hepatitis C were actually unaware of their infection. And at the time, we knew 2.4 million Americans were living with hepatitis C. The prevalence of hepatitis C was highest among the baby boomer population, and about 2 million Americans were living at the time with hepatitis B. But we knew that we had these tools, we knew we have the knowledge, and that is that vaccination and screening for viral hepatitis were key to prevention and early detection of liver cancer. And so those reports, the data, really served as our blueprint for our first demonstration project. And what I want to share here is the critical need for partnerships. So CDC relies on partners. We rely on our programs and their coalitions to support the work that we do. So we onboarded the Cherokee Nation Comprehensive Cancer Control Program, as well as the Idaho Comprehensive Cancer Control Program. Idaho partnered with their immunization bureau because at the time they were seeing a decrease in vaccination rates of hepatitis B, and they were concerned about that. Cherokee was dealing with hepatitis C, and they have the Cherokee Nation Health Services, along with the hepatitis C elimination program that's led by Dr. Jorge Mira, who's a liver specialist. And so we worked with both of these programs to implement several interventions in those communities. And I don't have the time to go into the details, but I'm just sharing here. At the bottom, you can see where the papers are published. We published the Idaho work with the Journal of Health Promotion Practice, and the work with Cherokee in the Journal of Preventing Chronic Disease. But the goal here I can share is that we were trying to improve the knowledge and awareness of the risk factor and the disease with the healthcare providers, the community coalitions, as well as the patient community. And the second goal would be to take and learn from the best practices, lessons learned, and scale it up to our other programs. So we're just working with 2 programs, but how can we scale and work with those populations of focus? A result of that first demonstration project was this development of an action plan. And this is where we were also in touch with our programs and listening to them. what the challenges that they were also dealing with was, how do we do this? How do we have the data, we have these strategies, how do you put it into action? And so we developed this action plan in hopes that they would have a resource to then implement those interventions in their communities. Now, at this time, and this is prior to the pandemic, prior to the pandemic and before the launch of the second CDC demonstration project that I'll talk about prior to 2019, we also were dealing with the opioid epidemic in this country. And so you can see from this data from 2004 to 2014, hepatitis C and the opioid injection rose dramatically in younger Americans. So among people in this age bracket of 18 to 29, HCV increased by 400% and admission for opioid injection by 622%. In the next age bracket, when you look at people aged 30 to 39, HCV increased by 325% and admission for opioid injection by 83%. So this data, this information served as the blueprint to our second demonstration project, which occurred from 2019 to present day. We just wrapped the project and are currently compiling the data and hope to publish the findings. It's actually been accepted to a journal. We're just in the process of publishing, and I'm happy to share that information when the time comes. But 4 programs that we did on board was the American Indian Cancer Foundation, Iowa Department of Public Health, West Virginia's Department of Health and Human Resources, and then Mississippi State Department of Health. Despite the challenges that the pandemic brought on us, they were committed to this work. And I just wanted to provide some examples of some of the evidence-based or promising liver cancer prevention strategies that they were engaged in. So one would be to improve access to HBV vaccination. So really focusing on expanding access to free vaccinations in pharmacies and other easily accessible settings, community health settings and other community-based settings. I do want to share that in this year in April, CDC, and if you have not read these guidelines, CDC published some updated guidelines that can be viewed on our website, and I'm happy to share this with the American Liver Foundation if there's any easily accessible to package it together so you can read the updated guidelines that were shared. And the second bullet talks about using patient navigation for treatment, medication-assisted treatment for opioid use disorder and treatment for hepatitis. So really looking at patient navigators as a strategic approach where the nurses and the patient navigators can work directly with this population of focus, the opioid users, to link them to treatment. Implementing targeted naloxone distribution. This strategy also served as a channel for us to educate people who inject drugs about this connection between opioids, hepatitis, and liver cancer, and even provide an opportunity to connect with them on the vaccination and screening services that were available in their community. Educating communities, patients, and providers regarding the link between the opioid crisis and the hepatitis and liver cancer. And I'll talk a little bit in the next slide about specific activities around this, improving the delivery of viral hepatitis services. As you can see, these are all examples that fall under the National Academy's report of the type of interventions that we should be engaged in. So ensuring that all adults receive an HCV test at least once in their lifetime. CDC guidelines were updated for calling for universal testing in adults, and this is in 2020. And again, you can visit our website to read those updated guidelines. Encouraging providers to identify patients at risk for HBV and HCV and then assess for those risk factors and test according to those guidelines. Using the National Notifiable Disease Surveillance System data to improve opioid prescribing and treatment of hepatitis services. The surveillance system and our data is core to what we do at CDC because it informs, or allows us to look at trends, informs patterns of care, and even for us to be able to look at what the burden is in the community. Implementing comprehensive syringe services. So this is where we're hoping to provide additional social medical services, such as the safe disposal of syringes and needles, providing education, linking to treatment, as well as any tools to prevent the infection, such as vaccinations and counseling. Linking to treatment is also critical and has been discussed by our health departments and some of their partners on ensuring that that does occur. So I talked a little bit at a high level, some of the examples of those evidence-based interventions or promising practices, and I'll just very briefly provide some activities. So I mentioned provider education. And so Project ECHO is a project that was launched by a clinician in New Mexico, or founded by a clinician in New Mexico. And so what we did was we worked with Cherokee Nation, Dr. Mira, who already had a platform in place where he is a liver specialist, and he was delivering these didactics to primary care physicians in rural areas. And so it was it's a virtual platform where we incorporated some educational messaging and information around liver cancer prevention, signs, symptoms, how to diagnose, what the sort of epidemiology was. And we held about 8 or 9 sessions over a course of 6 months, and assessed pre and post improvement of knowledge and awareness, and also the provider's ability to speak with their patients around it and feel more comfortable around addressing those questions. Another example is hosting webinars that would offer these providers CME credits. Around patient education, it's conducting educational sessions. So again, we have our programs, we'll partner with the clinician, with the public health department, and to raise awareness, the knowledge and the awareness of the risk factors and the disease, and the ability and the attention for patients to talk with their provider, know if they're at high risk, and then get screened and vaccinated if recommended. Idaho actually put out a social media campaign on HPV vaccination, and also came to know that there's a large anti-vax group within the state, and there were some challenges that they had to navigate and some messaging that we had to step in to help them with. And so another example of how just a campaign, mass media campaigns or social media campaigns can help, but there are some challenges and barriers around disinformation and misinformation as well. Improving delivery of viral hepatitis services. So this was an opportunity in a community-focused environment with primary care providers who participated in those Project ECHO sessions to actually present cases of HCV positive patients, and then seek consultation to determine the appropriate course of treatment. And then finally, another example of an activity is to implement comprehensive syringe service programs. And really here is looking to conduct community engagement and outreach, and distribute harm reduction materials. We also the program provided mobile HBV and HCV screening and medical services during these outreach events. So when I think about moving forward, where we are now and where we want to go, I think from 2010 over these years, really to build on this work, that is our goal. We have received interest from other federal institutions that are aware of our work, that want to collaborate with us and help us scale up the work that we're doing. We would like to share our best practices and lessons learned, hopefully that the other programs would adopt some of these strategies and work with their communities on the ground and focusing on prevention and control. We, of course, stay abreast of these emerging trends like fatty liver disease could be potentially contributing to the increasing incidence, and then focusing on those populations as well. I want to end by sharing this slide because I talked a little bit about data from 2001 to 2006, and then again in the middle of my presentation from 2006 to 2015. But when I pull this data from 2015 to 2019, you can see here that there is some type of leveling off. Now I can't suggest anything, but something other than that, something seems to be working. And so it gives me hope. Of course, it's not where we want to see. We hopefully want to reverse the trend and bring that down. But we can look at the populations of focus here. We know that men are at a 2.5 times increased risk when compared to women, and specifically men in that age group. We've been seeing an increase in the Hispanic population in terms of their incidence. Of course, I mentioned earlier, Asian Pacific Islanders, American Indian, Alaskan Natives, and Blacks also have a higher incidence. But we really have been looking closely at the Hispanic population, which in the data is showing a high incidence, people who inject drugs, and then we're also taking a look at the emerging issues like I mentioned. Some key takeaways of how to move forward. I mentioned that we would like to move forward, but now how do we do it? I just will stress here the critical need for partnerships. As you can see, we work with our partners on the ground to achieve our goal. Resources are extremely crucial for them, especially right now during a time when they're juggling so many different issues with the pandemic and other diseases. So resources are crucial for them, ongoing technical assistance that we provide to them along with the coalitions, and then continued research and demonstration projects to identify the best practices, adoption, and dissemination. With that, I'd just like to end by thanking again the American Liver Foundation. I do want to thank the programs. I'd like to thank the Division of Viral Hepatitis at CDC, and I'd also like to thank ICF, who's been a great collaborator with us. So thank you.